Welcome. Thank you for joining us. My name is Michaeline Friedenberg, and I'm the President and CEO of the Institute of Reproductive Grief Care, coming to you today from our headquarters in San Diego, California. For those of you who are new to the Institute, let me start by briefly sharing our mission and the goal of this webinar series. The Institute of Reproductive Grief Care is the global expert in evidence-based grief care education and training for healthcare professionals, mental health providers, and community leaders. We're at the forefront of creating and distributing impartial and impactful research to understand the way individuals process reproductive losses so that we can establish global standards for offering compassionate care. Our quarterly Research Reveals lecture series features in-depth discussions with the authors of some of the latest groundbreaking reproductive loss research. Today, we have an exciting lineup of experts who serve on the Institute's Screening Tool Working Group. They will be giving us an exclusive update about the screening tool and invite you to be part of the process as a research ambassador. With 2.4 million reproductive losses per year and up to 60% experiencing symptoms of anxiety, depression, or PTSD within 2 years of the loss, this screening tool is urgently needed. So I'm going to start by introducing the panel. Coming to us today from Texas is Dr. Kara Bussmiller. She is a board-certified obstetrician gynecologist and maternal fetal medicine physician who currently offers fetal intervention at Texas Children's Hospital, North Austin. She also holds a master's degree in ethics, and her research interests include reproductive loss, perinatal palliative care, and fetal intervention device design. From Indiana, Dr. Maria Bran. Dr. Bran is a professor in the Department of Communication Studies at Indiana University, Indianapolis. Her research focuses on understanding the interpersonal communicative negotiations and societal view of reproductive loss and grief, and the promotion of more empathetic provider communication during bad news delivery. Also from Indiana is Dr. Jennifer Butte. Dr. Butte is a professor in the Department of Communication Studies at Indiana University, Indianapolis. Her research centers on communication about health in interpersonal relationships and patient-provider interactions, mostly in the context of reproductive health. From right here in San Diego, Dr. Rebecca Madsen. She is an assistant professor of nursing at San Diego State University, specializing in reproductive health and social determinants of health. Dr. Madsen's research spans multidisciplinary and innovative areas. Also from Texas, Dr. Gloricel Vieira. She's double board certified in psychiatry and sleep medicine by the American Board of Psychiatry and Neurology. She's an assistant professor at Baylor College of Medicine, where she works as a reproductive psychiatrist at the Women's Place at Texas Children's Hospital Pavilion for Women. And then finally, from West Virginia, Dr. Jerica Wesley. Dr. Wesley is a licensed professional counselor with over a decade of experience providing services in schools and communities, working with both youth and adults. Dr. Wesley currently serves as an assistant professor at Marshall University, focusing her research on supporting women and families experiencing reproductive loss. So I want to thank everyone on our panel for joining us here today. And Dr. Bussmiller is going to be starting us off with phase 1. But before we do that, I want to encourage you, all of you who are participating, to submit questions throughout the panel presentations. If you could do that in the Q&A box. And when you do it, just to help me out, if you would indicate either the phase or the name of the panelist, because that will help us during the final part of this presentation for me to direct those questions appropriately. So we're going to kick off right now with Dr. Bussmiller and phase 1.
Thank you so much, Michaeline. So I'm a healthcare provider, and I'll be the first to admit that healthcare providers are often rushed and don't pick up on difficulties that follow some of these very impactful life experiences that include reproductive loss. So it's difficult in the clinical setting to pick up on these situations, even though it really shouldn't be. We are very good now about using detection systems like the Edinburgh Postnatal Depression Scale for perinatal depression, and that works really well for that. But in a busy clinical setting, we don't have a way to help us ask difficult questions, and often, unfortunately, healthcare providers choose the easier and bad path of not asking enough questions about complicated grief. Complicated grief isn't like typical grief, which is a normal process that all of us go through after something difficult and permanent like a reproductive loss. But complicated grief makes us unable to focus on other aspects of life, makes us isolated, feel numb, blaming self, focusing on reminders, and kind of being unable to move past and integrate that experience with the rest of our life and with the world. And we don't have a good tool to pick this up after reproductive loss, but luckily a good tool does exist, which is brief, 5 questions, and is used in other specialties for adults who are mourning adults, and that's called the Brief Grief Questionnaire. It's been validated, which is a process that makes sure the instrument is measuring what it's meant to measure, and it measures it well. It's been validated with many languages across many cultures. So we contacted the Brief Grief Questionnaire writers and asked if we could modify it to see if we could make it more useful for reproductive loss and complicated grief. So we did modify it with a multidisciplinary group across multiple institutions, including the ones that you see represented here, but also others, so that we could make sure that we didn't have anyone who was defending something they thought would be particularly good, but wasn't actually of general interest. We administered that survey to 140 women who'd had a reproductive loss. We also, at the same time, had them take surveys that measured anxiety, trauma symptoms, and actually they also took a third very long survey, which was designed for reproductive grief, but is cumbersome for use in general practice and actually puts up more barriers to clinicians asking questions. And those 140 people were recruited about half from social media, half from in-person practices, and showed us that we hadn't completely broken the Brief Grief Questionnaire by modifying it, but it no longer met the highest standards of validity. It did meet the standards of validity for investigator-designed surveys, which is great. But we also had some participants kind of reach out and say, hey, this wasn't the nicest experience for me. Let me explain to you why. So we knew that even though we had a 5-question survey that could be used in practice, and it met some standards for investigator-designed surveys, which is what this was, we still hadn't met the highest level of validity statistics. Our survey perhaps wasn't measuring what it was meant to measure as perfectly as it ought to in this vulnerable population. And we also had some participants who we knew had a difficult time taking the survey, as this is a very high-risk time for re-traumatization. So our thought at the end of phase 1, which happened in 2021 and 2022, was that we needed to continue to modify this survey, optimize it for the population it was meant for, so that we can raise ourselves to the highest standards and make it possible for people to screen for complicated grief in busy clinical settings. Thank you, Michaeline. That's a quick summary.
That's a fantastic summary, Dr. Bussmiller. And I am so grateful to you because you were the first one outside of the Institute to believe in this. I believe that within the studies, within your learning management system, when you got in there for the course, there are handouts that do have the published results of what Dr. Bussmiller was just referring to, which then you set us up nicely. We realized we needed to add another phase that we did not anticipate. And to walk us through that is Dr. Maria Bran.
Thank you, Michaeline. Yeah, so as Dr. Buskmiller said, we were really interested in getting women who experience this type of loss, their voices, and to understand their perspectives, so that way we could create this tool that would do what we wanted it to do without harming them, without re-traumatizing them. So for this phase of the research, we conducted a mixed method study that included interviewing 27 women and then surveying 282 women from across the United States who had experienced reproductive loss, specifically miscarriage, stillbirth, or abortion. First, we spoke with women about their experiences with pregnancy loss, their interactions with healthcare providers, and then their perceptions of the reproductive grief screening tool. And specifically related to the screening tool, we wanted to know their preferences for the wording and administering the tool so that way we could have the most effective tool possible. We analyzed that qualitative data through a phonetic iterative analysis and then used the results from that qualitative portion to inform our survey development. And that included questions about preferences for ongoing screening following a loss, and then again, getting more at some of the wording and administration. And we analyzed that quantitative data then using some descriptive statistics and chi-square tests. And so what we found was that all of the women who were interviewed and the majority of the women who were surveyed, actually 3/4 of the women who were surveyed, believed that it would be helpful for a healthcare provider to check in with them about how they are coping after a pregnancy loss. And they actually called for a quote unquote standard of care to do this. And one thing is they found that the screening tool might actually be that standard of care because they thought it was a very useful tool for promoting communication about grief following a loss with healthcare providers like OBGYNs, primary care physicians, and mental health specialists. They thought that it validated their emotional pain that they felt from that loss. In terms of some of their preferences, they preferred to complete the screening prior to an appointment so they could choose the time and location to engage with that screening tool. They did not want to complete it in a waiting room. Instead, they really preferred to complete it either before arriving on site for an appointment, which they suggested they could either receive a text message with a link to that screening tool or direct them to the patient portal to do it. Or if it was going to be done on site, they really wanted to be able to complete that in the privacy of an examination room. The women shared that that screening tool should be used multiple times throughout that first year following a loss, and then yearly thereafter with OBGYNs and primary care physicians. And they also thought that it would be really useful for mental health specialists to use this, but they deferred to them on the frequency of use because we know that you often spend more time with a therapist than just like a yearly check-in you would with a healthcare provider. So the women preferred to complete the tool independently, online, prior to an appointment, but they really stress it's important for providers to discuss the screening with the patient. They want a conversation. They want to discuss their experiences, and they want to know that the provider is paying attention to the information that they're providing. The women also had some specific comments about the wording of the items to make sure that the screening tool actually captures their experiences without being triggering. And so we have taken that information to inform our current phase of the study, which is phase 3.
Thank you. Thank you, Dr. Bran. That's a great summary. And I just, again, was reminded how much I love it that we took the extra step to reach out and actually talk to those who the tool would be administered to. And as Dr. Bran said, in that study that actually took us to phase 3, which is where we're at actually right now. And to walk us through that is Dr. Jennifer Butte.
Thank you, Michaeline. So yes, phase 3 is currently underway, and this is a really critical part of making sure that the reproductive screen is designed in a way that includes optimal wording for the 5 items and also a suitable combination and order of the items. Because we are designing this tool to be used in clinical settings, it needs to be brief. So it's 5 items. And we really want to make sure it's brief so that it's more useful for both patients and healthcare providers. So we don't want to burden patients with a really long survey for them to fill out. And we want to make sure that healthcare providers do have time to interpret and discuss the items as Dr. Bran mentioned. So it's especially important that each of the 5 items is very thoughtfully designed. As Dr. Bran said, participants in phase 2 did identify several items that they found to be problematic in some way. So for example, they thought one of the questions was just confusing. They weren't exactly sure what that question was trying to get at, what it was asking them. So obviously we needed to tweak the wording of that question. There was one question that they found to be unnecessarily lengthy, and it's quite clear if you look at the version we used in phase 2 and visually see all 5 of the items, one of them was much longer than the others. and probably didn't have to be quite so different as the other 4 items. Finally, then there was one item that participants found the wording to be off-putting or maybe even triggering in how it was worded. And these were recurrent themes across the qualitative study from women who had experienced a variety of types of losses. So we then verified some of these opinions on the wording of items through the survey data that we gathered in phase 2. And so what we're doing is in phase 3 is a more in-depth comparison of various versions of the items. Really, we want to get the wording right. And so we're incorporating the voices of women we talked to and surveyed during phase 2. We rewrote some of those problematic items so that in phase 3, we can ask people which versions of the items they prefer. In addition, this current phase also includes various iterations of the screening tool. So this ensures that we have the most useful and valid combination of the items and order of the items. And so our goal is that the final result of phase 3 will be just a really well-crafted and well-tested version of the RGS. Because of the nature of the phase of this study and some of the analysis we have to do, we need lots and lots of participants for phase 3. Recruitment for participation in phase 3 is actually ongoing, and we're going to discuss later how you can help us with phase 3 of the study.
Thank you, Dr. Butte. Thank you for that great overview. And like Dr. Butte said, we're going to learn how we can help to actually recruit the study participants that are needed throughout this phase. But before we do that, we're going to look at the next 2 phases. So once phase 3 is done, what does the future hold before this tool is fully validated and ready for your use? And to do that for phase 4 is Dr. Rebecca Matson.
Yes, so for phase 4, once we move into this next phase of our study, we will focus on confirming the validation of our screening tool with the 5-item RGS identified from phase 3. So this will involve comparing it to a well-established instrument that measures perinatal grief, depression, anxiety, and trauma symptoms. The validation process is a critical step because it makes sure that our psychometric instrument is effective and reliable in capturing the full range of emotional and psychological challenges women may face during and after pregnancy. So we anticipate that our tool's reliability scores will fall between 0.75 and 0.82. So this range is consistent with the scores we see for other validated instruments, such as the Brief Grief Questionnaire, which is widely recognized for its accuracy in assessing grief and related emotional states. Our goal is to have 150 participants complete the survey during this phase. These participants will provide us with the data we need to ensure that our tool is valid and practical for use in clinical settings. Ultimately, our aim is to create a resource that can help healthcare providers identify and address the mental health needs of women who may be struggling with reproductive grief, depression, or trauma.
Thank you, Dr. Matson, for giving us a peek at what's going to be coming ahead in the future. For our final phase, or what we anticipate is going to be the final phase, is phase 5. And Dr. Gloricel Vieira is going to walk us through that. And she's actually going to be the person who is going to be administering this part of the study.
Thank you so much, Michaeline. So in this last phase, what we're going to be doing is that we're going to calibrate the screener. So that means that we want to determine how powerful this screening tool is to identify complicated grief or prolonged grief disorder. And also we want to know how well it discerns complicated grief from other psychiatric conditions. And so there are 2 main components to the interview that I'm going to be administering to these patients, to these research participants. So they will have completed the RGS, and I will be completely blinded to the results of their survey. And so when they come to me, I will be doing an interview that's going to have two main parts. One of it is the structured clinical interview for complicated grief. This is a tool that has been created and validated to assess complicated grief. And it was created with the specific aim to be used in research and in clinical practice. So it is the gold standard to diagnose complicated grief. So it asks about the different criteria for diagnosing complicated grief, such as wanting to go back to the time before the loss, feelings of loneliness, wishing to die to be able to be with the loved one that has passed, intrusive thoughts, excessive worrying, trouble accepting the death of the loved one, and then feelings of numbness, anger, emotional reactivity, and other physical symptoms and avoidance of the reminders of the person that has passed away. The second part of this interview process is a semi-structured interview based on the Pocket Guide for DSM-5 diagnostic exam, where we use criteria for the diagnosis of the most common psychiatric conditions, such as generalized anxiety disorder, PTSD, major depressive disorder, which those three are the most common psychiatric comorbid conditions with prolonged grief disorder. But we will also be assessing for other common comorbid conditions, such as some sleep disorders, for sleep disturbance. And then also we want to diagnose for some somatoform disorders as well. And so what I love about this aspect of this last phase of the study is the human aspect, right? So this is an interview that's one-on-one, it's very personal. We're not going to re-traumatize patients during it because we're going to be able to provide validation, reassurance, and education based on the findings that we're having during that interview with them. And so if the participant decides to know, hey, do I have something that I need to be concerned about? I can share that with them. And then I can share the necessary resources so they'll be able to have the proper follow-up. So like Dr. Buskmiller was talking about in the beginning, we don't want to pathologize grief, right? Isolated grief is something that's common that happens when someone that we love passes away. But we want to be able to identify patients who have complicated grief or prolonged grief disorder because we know they are at an increased risk of other psychiatric conditions and also of other physical conditions based on some correlations that have been found, and even at an increased risk of self-harm in some cases. So we hope that this tool can be used by providers in the primary care setting, that it's easy enough to be given to patients so we can identify those patients that are at risk for developing prolonged grief disorder or complicated grief, so they can be referred to the necessary resources and obtain the help that they need. So thank you so much, and we hope you join our efforts.
Thank you, Dr. Vieira. That's beautiful. And then to do that, to talk about how you can get involved, Dr. Jericho Wesley is going to be sharing that with us. I also do want to make a comment right now because once Dr. Wesley concludes this is our presentation for you. And now we want you to get involved, not only in helping us to recruit participants, but also asking questions right now. So there is a Q&A box. And so I would encourage you to start putting your questions that are there while we bring Dr. Jericho Wesley to tell us how we can get involved specifically with phase 3.
Well, thank you. And I'm honored and excited to extend this invitation. We need your voice. Your experiences are unique, and by sharing them, you're helping us to shed light on the profound mental health impacts of pregnancy loss. So we invite you to be a vital part of this groundbreaking research where every voice matters. Keep in mind that your story can create change. Participation in this study not only benefits you by contributing to our understanding of grief, but it also creates pathways for future policies and support systems that will better serve individuals with similar situations. So keep in mind that we want to ensure you that participation in this study is entirely safe and confidential. Your responses will remain private, and the data will be used responsibly and ethically to advocate for more effective mental health interventions. And as a result, we need more diverse experiences in our research. Reproductive loss does not always affect everyone in the same way, and it's vital to capture the experiences of all individuals, especially from underrepresented and marginalized communities. This is crucial to understanding how cultural, social, and economic factors influence grief and healing. So inclusive representation matters. If we are to create support systems and interventions that work for everyone, we must have a diverse set of voices in this research. So we encourage participants from all backgrounds, including racial minorities, LGBTQ+ individuals, and others who share their stories. And by doing this, this will allow us to fill a gap in mental health understanding. Despite the prevalence of pregnancy loss, there is a significant gap in understanding the psychological impact, especially among minority populations. So again, this research seeks to close that gap by focusing on grief, depression, and anxiety, and other mental health symptoms post-loss. The data that we collect will help inform clinicians, policymakers, and advocacy groups in creating effective, compassionate support systems for individuals and families affected by reproductive loss. So how can you help, right? What are some actionable ways that you can support? Spread the word. Help us get the word out. You can play a crucial part in amplifying this message. Share this study with your networks, your friends, communities. The more people we reach, the more impactful this research will be. And encourage others to join, whether through social media, community groups, or those one-on-one conversations. Encourage others who have experienced reproductive loss to participate. Let them know that their stories are valid, valued, and needed to create change. So I encourage you, please become a change maker. By joining as a participant or research ambassador, you become an advocate for improved mental health services for those impacted by reproductive loss. Your leadership in this space can inspire others to contribute, share their stories, and foster a more supportive environment for those in need. So consider leading and lending your voice to this growing movement. As a research ambassador, you're not only contributing your experience, but also leading that movement that demands attention to reproductive grief and trauma. Your involvement can help set the stage for meaningful dialogue and societal change. So I hope you'll join us. Thank you.